Good morning. Is that on?
Yeah, I can hear you.
Good morning. Not loud enough yet.
Can you give us some volume?
Can you give us a volume? You got your volume now.
Okay.
Good morning. If you'll go ahead and take your seats, we'll get started with the Georgia House Rural Development Council meeting. Well, good morning. Well, no, I don't. Good morning and welcome to our Statesboro meeting. We look forward to this meeting for some time. We hope that it will be beneficial to you as we have put together a very, very good program for you. And we look forward to hearing from the presenters this morning. At this time, I'd like to call on the co-chair of the committee. I started to call you by your real name, the Reverend. Representative Mike Jackson for a prayer.
Thank you, Mr. Chairman. Good morning, everybody. Welcome to Statesboro, to our RDC meeting. Let's pray. Heavenly Father, we thank you for this day. We thank you for another opportunity, Lord, to do the business of the state of Georgia. We ask for your grace and your mercy, your wisdom as we go about this important business, Lord. And we'll be sure and give you the praise, the honor, and the glory. In Jesus' name, amen.
Thank you so much for that prayer. And those are words to live by and guide us as we go into this. I'm going to call on Dr. Carl Reiber to come forward, and Dr. Reiber will introduce the individuals from the Georgia Southern University. The podium is yours, Dr. Reiber.
Thank you so much. It is just a wonderful opportunity to be here. First, I want to say a welcome from President Kyle Marrero. He has to be in Atlanta today for a Sunbelt Conference meeting, but he wanted me to send his thanks and welcome to the university. He was very disappointed he couldn't be here. As introduced, I'm Dr. Carl Reiber. I'm the Provost and Executive Vice President for Academic Affairs here at Georgia Southern University, and I want to formally welcome you all to Georgia Southern University, and we thank you for having your meeting here. Off script a little bit, rural engagement is a passion of mine. It's a passion of many of our faculty. Where we are located encompasses many rural communities. I know that is the passion of everyone in here, and so this is a very special event for us because this is something that we are deeply committed to. And to that end, what I really would like to outline very quickly for you are some of the programs that we've been involved in and are putting forward to work through and build up the vibrancy and resiliency of our rural communities as initiatives here at Georgia Southern University. As Southeast Georgia's research university, Georgia Southern is proud to play a role in not just participating in events like this, but truly fully engaging as a partner in rural development and community establishment with not just individuals, but communities and entities that build out our rural vibrancy and resiliency. Georgia Southern University has a long-standing and deep commitment to the development of resiliency of rural communities. I'm going to just rattle off very quickly a few areas that we've invested in before we get to the main show here, two people that are really doing a lot. Our Business Innovation Group, BIG, headed by Dominique Hullaby, has bricks and mortar facilities in Statesboro, in Metter, and in Hinesville, and is getting ready to expand in a very large fashion to many other rural communities to build out innovation, entrepreneurship, and business planning that is specifically focused on the challenges of rural communities and rural development. Our College of Public Health has a wealth of programs and initiatives that are engaged in rural development, from rural hospital technical and financial input and advice to some of the core issues that we see in many rural communities, like addiction and recovery, pediatrics, nursing, et cetera, and training. These are vital in terms of rural communities and their overall health, but also employment. We also have our Waters College of Public Health, which is one of the largest producers of healthcare providers in terms of nurses, physical therapy, occupational therapy, et cetera, in rural communities. And we're very, very proud of that. Our students, for the most part, come from rural communities. They want to live in rural communities. They want to give back to rural communities. And these are great professions that they can go into. Our College of Education, we have made many forays into rural communities that we've committed to over the years. It used to be the dual enrollment, where we engaged high school students in college courses. The students would come to campus to take courses. We're now embedding faculty in the high schools so that those students have the opportunity to take courses. These are critically important for those students so that they can gain an education and build out their portfolios so that they can become vital members of the community and work with those communities to grow them and develop them. And so these are just a sliver of the things that Georgia Southern does in terms of engaging with rural communities and our passion in that area. But really and truly what we wanted to do here this morning was have two individuals who truly have built from the ground up two programs that are extraordinary in terms of engaging rural communities, rural health, in very different areas in different ways, that are going to talk about what they're doing and how they're engaging. And so it is just, this is where I get to get out of the way and have just great people come up and talk about what they're doing that are so and so enthusiastic. So first up this morning is Dr. Jessica Schwind, Director of the Institute for Health Logistics and Analytics. When she is a ball of fire. You're going to love Jessica. And then after Jessica is Dr. Asli Aslan, the Director of the Institute for Water and Health, who is also a ball of fire and has tremendous ideas. So Dr. Schwind.
Hi, y'all. Thank y'all so much for allowing me to be here. So my name is Jessica Schwind, and I am an infectious disease epidemiologist, and I'm the director for the Institute for Health Logistics and Analytics. So I'm going to tell you a little bit about the Institute today. The Institute's mission is really about transforming the health and well-being of our communities through evidence-based practices and technology integration. We do that by focusing on like three main core areas. The first one is analytics and informatics. Being an epidemiologist, I love data and I love using data in order to implement programs. So in order to analyze the data and follow through with that implementation, it's really important that we have a firm foundation in analytics. Also informatics, so being able to bolster the local information systems in order to gather that data, promote data exchange in order to advance rural health is something that we're really passionate about at IHLA as well. So moving on to planning and evaluation, we really love engaging with the community in order to implement programs for the community's health. That's something that we take very seriously. And then we also follow up with evaluation procedures. So we know we're not just running these programs because they sound good or they feel good, but ultimately because there's data to support the implementation and the continuation of these programs. And then finally, logistics and training. So during the pandemic, we saw that there needed to be rapid movement of health-related materials. And so we got into the field of logistics in order to help the state through various partnerships. Then, of course, in addition, a skilled, strong workforce is really a focus as well. And so we help out with training. I really want to talk to you today about our vision at IHLA. Our vision is really looking at the multifaceted health components of rural communities and really going into these communities and meeting people where they are so that we can not only improve their health, but really give them sustainable solutions. That's something that we love to do in IHLA. Now, IHLA was really started in January of 2022. And so we haven't been around too long, but we have seen a lot of successes in a lot of different areas across the state. We have worked in close partnership with the Department of Public Health, especially in their epidemiology and laboratory capacity grant through the federal government, focusing on COVID-19 mitigation in K through 12 schools, as well as ongoing in confinement facilities. So we were able, through this partnership, to put HEPA units and provide other COVID-19 mitigation supplies in over 1,200 K through 12 schools throughout the state, both public and private, and we're really proud of that. And then we're continually working with confinement facilities as well. In addition, we were able to secure 2 Department of Labor grants through OSHA in order to improve workplace safety and health. And our focus, again, because it's rural communities, was really getting into small businesses and the agricultural sector, so agribusinesses, and showing them that, hey, when we have safe and healthy employees, we also have more productive employees. So it's a win-win, especially in terms of like economic stability and security. So we've been really happy to team up with the Georgia Department of Ag there. At the heart of all of this is research, service, education, and innovation. One thing that we always talk about in our team is really, we can't keep offering old solutions to old problems, because if we still have the problem, clearly it's not working. So we focus on innovative solutions, meeting people where they are, so that we can really start to move the needle in terms of rural health. So some of the areas that we're going to really focus on in the next 3 to 5 years is looking at how IHLA can help strengthen the health informatics infrastructure in order to promote data exchange. Also really promote that cross-industry partnership. We saw that a lot of people were called to the mission of public health, right, during the pandemic. And it didn't matter if you had a background in public health or not, because ultimately we saw that health affects everybody and affects all aspects of rural communities. And so we really want to address this and capitalize on it through the Total Worker Health framework. Again, if we focus on improving worker health, then that will pay dividends throughout the community. Also, we want to continue to contribute to the evidence base. We want to study what works in rural communities and what doesn't. We want to learn from the successes of other programs and address the weaknesses that we see, not just from Georgia, but throughout rural communities throughout the United States. And then ultimately, we want to help build that infrastructure. We don't know what's coming next. One area that I really focused on before the pandemic was emergency preparedness and planning. Now that we're moving out of the recovery phase of this pandemic, I'm going back into the preparedness phase. And that's really something that I want to pass on to rural communities. Now, rural communities, of course, as you all know, are very unique. It's not a situation typically where everybody operates based in their area of expertise. Oftentimes in rural communities, we have, population size very small, and then there's a lot of integration. So for example, in my rural community, a CNA may be also acting as the local public health professional, right? And so we saw a lot of information flow throughout rural communities, and what we really saw is we need to work with people who are outside of traditional health roles to really start to advance health. So for example, if you have a primary employer, such as a K through 12 school or such as a private prison, then that's really going to be your gateway to addressing the health in rural communities. And so one way that we do that is by really approaching rural health with the social determinants of health in mind. That means really taking a holistic view and saying, okay, we can't start to address healthcare access and quality if we don't address economic stability, if we don't take into account the social and community context. When we talk about neighborhood and built environment, the place where people eat, live, work, play, sometimes in rural communities, it's within, a couple miles radius, right? Other times people have to commute far for jobs. Taking into account all of these things is really important for the advancement of health. And so that's why we're really going to start engaging in community asset mapping at IHLA. So if you've heard of like needs assessments, a lot of people go into communities and say, hey, this is what you need, right? But from IHLA, we're really approaching it from looking at the strength of a community. Hey, this community looks really strong in this area. How can we capitalize on this area in order to then impact health in a variety of ways? And, sometimes people like to lump rural communities together, but I'm here to tell you, one rural community that has a strength in one area, right down the road may not see the same strength, okay, in a different community. So that's when we start to look at the assets of organizations, individuals, and associations. And then ultimately, this is what's really important to me is we're not just gathering the data for the sake of gathering data. Instead, we're actually getting the data to the local stakeholders who are able to use it, in order to further their mission and to improve rural health. Now, behind every good director, there's an awesome team. And so at IHLA, I have a really, really awesome team. We come from, diverse backgrounds, and we all have different strengths. Just to tell you a little bit about myself, I was raised on a farm about an hour and a half away from here, Wheeler County, where the county seat's Alamo, Georgia. My father is a cotton and peanut farmer. And my mother is a nurse, and so rural health was frequently brought up at the dinner table. In fact, it continues to frequently be brought up at the dinner table. My background was, as I said, in emergency planning, preparedness, pandemic prevention, early response. I moved across the United States. I lived in New York, California for a while, moved around, but then I decided to bring my twins back and raise them on the same farm that I grew up on in Wheeler County, and that's where we currently live. So I come to you like with a professional background in studying agricultural sector, and I also grew up in it as well, and continue to raise my kids there too. So I'm just so thankful for the opportunity to speak to you guys, and I really want to play a huge role in building that infrastructure that's going to be important for weathering whatever health crisis may be coming next, especially as we see widening health disparities in rural communities. So thank you.
Good morning, everyone. So I'm the director for the Institute for Water and Health, and today I'll be talking about what we have been doing for the last 2 years since our establishment. So our mission is uniting science, practice, and community funds of knowledge for a better future for Georgia. We have been working with a variety of faculty members and external and internal affiliates on issues related to water. In Georgia specifically, water is a major challenge with the increased climate change, saltwater intrusion, increased economical activities. There is more water, and as more people come into Georgia, there will be more need for water as well. And here at Institute for Water and Health, we're trying to help communities on how to improve some of these challenges that they're facing in their everyday life. We have 3 focus areas. One of them is sustainable water and wastewater management. The other one is water quality and health risk assessment. And the third one is environmental education and justice. So all of these issues are really in the focus area of water. One of the projects that we first take on was really looking at how much water we have in Georgia. We have been using data from existing gauges over across 16 areas in groundwater wells to really figure out how much water has been and how much water is being used and what are the current policies and how are they impacting our future to be able to access to safe water in Georgia. We developed a dashboard that really helps the Water Resources Planning Council that develops future policies moving forward. This was funded by the Georgia Department of Environmental Protection Division. One of the other things is I'm an environmental microbiologist, so most of my work has been around how humans are impacted by the environment and how human activities really in turn impact our environment. It's a two-way problem, right? So environmental microbiology really helps us to solve some of these problems. We have tremendous amounts of technology and advancement in our labs, but how do we bring that technology back to our communities and solve some of the problems that are for the communities? So we have been working on some of the rapid testing methodologies. We are working closely with the EPA, and some of our methodologies have been approved, and we've been working with some of the local communities here. City of Savannah, for example, they have had serious issues with their stormwater and environmental waters. Septic systems, aging infrastructure, they all impacted their environment. We do have methods that specifically identify if that pollution is really coming from a septic leak. And you can do this within a day, in 4 hours, and give the results same day to the municipality, to the decision makers, so that they can go back and be able to fix that problem permanently. That also supports policies to be able to support the private wells. How do we improve the private wells as well? So one of the things that we have been doing specifically is working with our communities and educate them, especially around how they can specifically improve their private well water quality. As you know, private wells are not regulated by any municipalities or public health. So it's really up to the owners' responsibility to be able to make sure that their wells are safe. We have 1 in every 6 households in Georgia that are on private wells in our rural regions. Therefore, it's really important to make sure that the communities know what are the potential problems related to that. We have been working with specifically some of the counties as a pilot. We started with Adams County. This county has significant number of high levels of cancer incidences and a very agricultural area. So they've been approaching us about how do we actually work with the community to identify some of the issues in their water, for example. So we've been doing surveys and visiting their homes, testing for their well water, and then through town halls and listening sessions and interviews, we're trying to understand, do you treat your water? How often do you treat your water? Do you maintain your well? Do you know what are the potential problems related to that? So we go into that details and work with the community. Some of the results we found that of the main county residents is that there is no significant maintenance or chlorination in the water wells. And that really impacts not just for potential problems related to, E. coli and pollution, but also aging infrastructure where we have a lot of old homes that really needs some maintenance, and those old homes and pipelines may be promoting emerging contaminants that will also be impacting our aging populations. We also take all these technology and see, okay, we have maybe problems, but how do we solve them? How do we take those technologies to the communities? So one of the things that we're working on recently is using nature-based products to clean water and serve the communities. We work with some agricultural regions and farmers in Dodge County, where we install algal turf scrubbers. These are basically channels, mesh channels that grow algae. If you run irrigation water, for example, or any type of water that may potentially have sources of pollutants in it, it can actually remove those contaminants significantly. We just recently found out there is 65% reduction of antibiotic-resistant bacteria in a farm irrigation water where, cows were in there and children were playing. So there is some potential there. And how do you take that algae then when it's grown and use it for, let's say, biomass production? And that will be important for a farmer, for circular economy. So we have a group of 17 affiliated faculty all working in water area in Georgia Southern. We have about 50 community partners right now that are working with us to develop solutions for the problems that they've been facing around water. Thank you for listening to me.
Thank you so much for those informative messages there. Georgia Southern has come a long way since I was here in college, and I'm just delighted to be on their campus today and be a part of this. I'm going to call on the state representative from this area, Representative Lehman Franklin. If you'll come forth and you'll introduce the mayor, the chairman of the county commission, and your state senator. We were delighted to see Billy Hickman up in Athens and listen to him at the Rural Summit there, and we were very pleased with the statements that he was able to make. So if you would, Representative.
Well, thank you, Mr. Chairman. I appreciate it. And I'm not going to take much of your time, but I do really want to thank you guys for coming down here. I think we have 3 to maybe 4 different committees going on in Statesboro today, which is awesome because, it gives us a chance to hear what's going on with, you guys doing God's work in Georgia. And so I appreciate it so much. But I do want to introduce our mayor first, if I can, Jonathan McCullough. If you can come up. And then right after him will be our county chairman, Roy Thompson. And then, of course, Billy Hickman, as everybody knows. Thank you, John. Mm-hmm.
Good morning, everyone. We want to thank you for coming out and being in Statesboro today. There's 3 things I want to tell you before you leave. Spend lots of money. Spend lots of money and then spend lots of money. We need the support of our SPLOS and T-SPLOS because as you're here, we want you to get a chance, enjoy the university, but take a ride around our city. We're doing some amazing things within our community. And I think that this is a great space for this conversation that you're having today. We believe that our community, though it's small in size, we believe that we're doing some powerful things within our community to move it forward. We're looking at our access to health for our public by establishing commissions that's addressing that very issue within our community. And then water, that's a big issue within our community right now. But with that being said, ladies and gentlemen, we definitely want to welcome you. We call Statesboro not only the city that soars, but a southern jewel, because if you need it, you enjoy it. It's right here in Statesboro. Take care and God bless each of you.
It's my pleasure to be here also this morning. I was looking in the audience out there, and I think I've got the whitest hair here. I've got one younger fellow there that Mike could run a race with me. But how many Braves fans do we have in here? Show of hands. I attribute my gray hair to the Braves. Everything was going great until 3 weeks ago. My hair was the color of the red in this Christmas tie. Then I started watching the playoffs, and the Philadelphia Phillies did this to my hair, and probably a lot of y'all others too. I always say this: I wish they would pay them by performance. Salaries might be a lot less. We need pitching, we need hitters, but enough to do about that. Welcome to Bullock County. At 77 years old, I am privileged to represent the citizens of Bullock County. And I appreciate the report a few minutes ago about the water studies. I think that's probably one of our biggest issues. Agriculture is still our number one industry in Bullock County. Most of the farmers here and a lot of other people think that when Hyundai agreed to come, that Bullock County, all the water is going to be sucked out of Bullock County and it's going to sink somewhere. So I hope she has answers for us. I'm telling you the truth. That's the biggest issue we have right now is where is the water going to come from? I invite you to do one thing. If you have time tomorrow, this evening, or whenever, drive down Highway 16, hit the Bullock County line, drive 5 more miles, look to your right, and you're going to see a 2-mile square area that has been cleared. That is where Hyundai is being built. And you're going to see 73 cranes down there. And it's amazing that what is happening, and it's all about the growth. But I say this like y'all would the county we live in. To Bullock County, this is the number 1 county in the state of Georgia. And we certainly appreciate y'all being here today. Thank you.
Well, thank y'all. It was great. I appreciate the y'all being here today, and I hopefully y'all you saw all the traffic in Bullock County and Statesboro and how we're growing. And as Chairman just said, we're just so fortunate to live in a vibrant community. And thank y'all for being here. And thank you for this Rural Development Study Committee being here today, and obviously through tomorrow also. As the Chairman just said, one of our big concerns is water. As we get further into this situation, of course, we all know, and y'all all know, that the Hyundai plant was just announced a little over a year and a half ago, and they're going to start up 1125, first car off the assembly line. In our community, I think our big problem right now is trying to balance agriculture, which is the number 1 industry in our community, along with development. We've got land prices that have skyrocketed around here, so it's a real challenge. So, but I appreciate you and every one of y'all. We work so close together in the General Assembly, and I appreciate the smiling faces here this morning. And thank y'all for being in Statesboro and Bullock County. Bye bye.
Thank you, Senator, and thank you, Representative. Y'all really serve your area well, and y'all are a great team to work with at the Georgia General Assembly. Y'all bring a great deal to the Assembly there, and we really appreciate y'all. And we are very delighted to be here today in Statesboro. And I'm going to call on Chairman Stevens, if you'll just introduce yourself. We don't go into it very much, just tell them where you're from.
Turn your mic on.
There we go. Thank you. I'm Ron Stevens. I represent Savannah and Chatham County, along with Bryan County, the fastest growing county in the state.
I'm Bill Yoder. I'm from Sylvester, Georgia, over in southwest Georgia. I represent Worth, Lee, and a portion of Daugherty County.
Representative Steve Tarvin from Chickamauga, Georgia, up in the northwest corner. Represent part of Walker, Catoosa, and Whitfield counties.
Good morning, I'm Lisa Hagan. I represent House District 156, all in 6 counties between here and Macon.
I'm Jason Ridley. I'm from Chatsworth, Georgia, District 6. I represent Murray County, part of Whitfield County, and part of Gordon County.
Good morning. Matt Hatchett from Dublin, just down the road, represent Lawrence and Johnson County. And glad we could get the senator to realize that the House, matters and that we do exist. Appreciate that, Senator. And Mr. Chairman, I'm pleased to continue to serve on this committee. We've been on it since inception and looking forward to some good things that we might be able to get done next session. Thank you.
My name's Darlene Taylor. I represent District 173, Thomas County, and most of Grady County. And I'm happy to be here too. And thank you for bringing us here. Thanks.
Thank you, Mr. Chairman. Thanks for all your work getting this together. I, like Matt, have been on it since inception. And I'm Rick Jaspers. I live in Jasper. I'm where everybody in Atlanta wants to be every weekend right now. Traffic is unbelievable, looking at leaves and buying apples. And I think we'll see some of those today or tomorrow from our neck of the woods. But thanks for being here.
I'm Mac Jackson. I'm from Sandersville, District 128. I represent Washington County, Hancock County, Warren County, Glasscock County, a portion of McDuff, and a portion of Baldwin County. And I've been on this committee since its inception, and I've seen some great legislation come out of the Rural Development Council.
I'm Gerald Green. I'm the co-chair of this committee, and I serve counties in southwest Georgia. I guess I have the largest geographical area in the state. I have 9 counties down there in southwest Georgia, and you're certainly always welcome in that area. And we have individuals that have come from 5 hours away that have driven here to this meeting today, and we're glad to be here.
John Corbett, District 174, 6 counties right on the Florida line, I-75 to I-95, Lowndes, Eccles, Clinch, Ware, Charlton, and Brantley counties. And I'd just like to thank Speaker Burns for continuing to reappoint this committee to continue the good work that we've done over the last several years, and look forward to what we can continue to do. Thank you.
Vince Wiegand, I'm at Legislative Counsel's office, and I live in Peachtree Corners.
Good morning. Good morning. Bill Williams. Glad to be here. House District 148. Bill, represent Chris, Pulaski, Wilcox, South House, and a portion of Ben Hill. Appreciate you allowing me to be here.
Robert Dickey, glad to be here as well. I represent 5 counties right in the middle of Georgia: Crawford, Monroe, Bibb, Peach, and Houston counties. And I'm farm when I'm not attending some of these committees in Atlanta representing my district. And I'm glad to know agriculture is still #1 industry in this area.
I also am a farmer. So I'm not an hour and a half from here. I'm 3 hours from here, cotton and peanut farmer, and represent the great district from Tata to Nichols in South Georgia.
We have 2 assistants over here that I could not do without, the committee could not do without, Stacy Williams there, and Leo Dempsey over there. They have been just great to work with. Thank y'all so much. Did we miss anyone?
Start opening.
Oh, I wasn't on. I was mentioning that we have 2 individuals over here that are assistants to us, Leo and Stacy, and they work with the committee, and we could not do without them. Thank y'all for what you do. And now I'm going to turn it over to the co-chair to introduce our first panel, or first group.
Thank you, Mr. Chairman. I too want to echo what Chairman Green has said. We couldn't do this without Leo and Stacy helping us to coordinate everything. And of course, the media staff that is here from Atlanta to help us to provide media coverage. We're going to get started, ladies and gentlemen, on our first speaker. And our first speaker will be Georgia Health Initiative, Rural Health, that will talk about rural health indicators. And that's Ms. Cindy Zeldin, Vice President of Health Policy and Government Affairs.
Good morning. Can you all hear me?
Yes, ma'am.
Yes. Okay. Well, good morning, members of the Rural Development Council. My name is Cindy Zeldin, and I am the Vice President for Health Policy at the Georgia Health Initiative. Some of you may know us as the Healthcare Georgia Foundation. We are a statewide foundation with a 22-year history of working towards a healthier Georgia. And just last week, the foundation announced our new name and a refreshed approach to our vision of a Georgia in which all people have the opportunity to achieve their fullest potential for health. So I'm really delighted to be here under our new banner, and hope some of you are familiar with our work in your communities. And if you're not, I'll tell you a little bit more about it as we go through the slides this morning. So this is just a little bit more about who we are, our mission, vision, and values. Our mission is really focused on achieving health equity for all Georgians, a Georgia in which all people have the opportunity to achieve their fullest potential for health. Our values are courageous leadership, trust, equity, and partnership. And so we work statewide. And rural health really does continue to be an important focus of our work. And the Georgia Health Initiative, please consider us here as a resource for you as you dig into the needs and challenges and assets of rural communities around the state. During my time this morning, I'm going to really do two things. First, I'm going to review some health indicators for rural communities in Georgia. And the purpose here is really to just highlight some of the needs and some of the disparities across regions of the state. And then after that, I'm going to share some of the learnings from a recent multi-year initiative that Healthcare Georgia Foundation, now Georgia Health Initiative, designed and implemented in partnership with 11 rural communities between 2017 and 2022. And that's called the Two Georgias Initiative. We had some really interesting outcomes from that effort. And so we'll go right ahead into the rural health indicators. So where we're going to start with this, and you should all be getting some fact sheets circulating that are specific to your districts or to the counties in your district. So we're going to start off really with the big picture and leverage some of the county health rankings data just to paint some statewide pictures at a county and regional level. So this is research that is done every year by the University of Wisconsin Population Health Institute, supported by the Robert Wood Johnson Foundation, and it measures the health of nearly every county across all 50 states. So if you aren't familiar with it, it's a really, really wonderful resource to look across numerous health indicators at the county level all across the nation. So the first map here represents health factors in Georgia. So this is a composite measure generated through analysis of data across multiple indicators, but in 4 overall categories: health behaviors, clinical care, social and economic factors, and physical environment. So you might think of things like alcohol and drug use, diet and exercise, healthcare access and quality, education and employment, water quality, housing. Numerous indicators are used to generate this picture. And the idea being that numerous factors influence health and well-being, not just any one factor. And so I also wanted to note that in addition to the actual rankings, which you can see here, and the darker shaded blue are the counties that are ranked lower relative to other counties in Georgia. And the counties in the very light blue shading are the highest ranking counties. The data is available, at the county level. So if there's a particular county where you would like to drill down, we're happy to work with you to pull some of that data and share it. Okay, and so the next slide looks kind of remarkably similar to the last slide, except it uses the color green rather than the color blue. This one represents health outcomes. And this is also a composite measure, and it includes indicators around length of life and quality of life. So things like life expectancy, also include things like infant mortality, birth outcomes, and physical and mental health. So you can see again here, the darker shaded counties are ranked lower than the lighter shade counties. So thinking about rural counties in Georgia and how rural counties fit into this picture, using the DCH criteria to classify counties as rural, that there's 120 rural counties, 39 non-rural counties, as you know, in Georgia. So I just did a quick analysis of these county health rankings for rurality, and it was pretty striking. About 3 in 5 rural counties in Georgia ranked in the bottom half for both health outcomes and health factors. And then conversely, fewer than 1 in 5 non-rural counties were ranked in the bottom half for health outcomes and health factors. So that's really the big picture across the state. So we know we have work to do, and we also know there are a lot of assets in rural communities to be leveraged. But that's sort of the big picture across numerous health-related factors and outcomes in our state. So the fact sheets that are going around are really just a snapshot. There are many other indicators. We selected 8 just to illustrate some fairly representative or kind of leading health indicators around the state. And these are the 8. We selected life expectancy, uninsurance rates for adults and children, diabetes and HIV prevalence, cancer incidence and mortality, and then some information about the health professional workforce. So we recognize, again, these are not exhaustive, and the reasons behind why the data are what they are can be really complex, and it can vary from community to community. But again, that snapshot. So these are the fact sheets. We were not able to pull partial county data, but we're happy to work with you if there are specific indicators that you're interested in for specific areas within the state. And this is an example of what the district fact sheets look like. Okay. So we wanted to just, again, draw out some of the high-level findings from these various health indicators around the state at the state level, looking at rural counties versus non-rural counties. Again, first being life expectancy, which is, of course, the average number of years that a person can expect to live. It's a pretty important population health outcome measure. So looking across counties in Georgia, there is a nearly 13-year gap between counties that have the lowest life expectancy and the highest life expectancy. So that's a pretty big range. And the average life expectancy value across rural counties is also a little bit lower than that of non-rural counties. Okay, so the next 2 slides are going to focus on health coverage statewide among adults ages 18 to 65 in Georgia. About 18% are uninsured, which is the 3rd highest in the nation. Overall in the US, it's 12%. Of course, health insurance is important because it facilitates access to care, can provide financial protection against high medical costs. Uninsured rates are higher in rural counties than in non-rural counties. And the average across rural counties is closer to 21%. And then looking at children, uninsured rates for children overall are much lower than they are for adults, but still relatively high in Georgia and slightly higher in rural communities in Georgia than in non-rural communities in Georgia. And as you all know well, health insurance for children is particularly important for regular access to screening, prevention, treatment services to keep kids healthy. Okay, so we selected just 2 population health indicators. There are many indicators that one could look at just to get a sense of the health, chronic conditions, overall health and well-being of a population. 2 examples here. We picked first diabetes. It is a very common chronic health condition. Prevention and ongoing treatment can be very important to addressing diabetes. So understanding what it looks like in a community is critically important. Diabetes here is slightly higher in non-metro counties, but not dramatically so. And this is among adults. And then we also wanted to show HIV prevalence. Of course, HIV is a major public health issue where prevention, detection, and treatment are really critical. HIV prevalence is substantially higher in urban counties of the state, particularly in Fulton and DeKalb counties, far lower in rural communities. However, we wanted to include it and also make a note in looking kind of county by county across the state that there is a cluster of counties in southwest Georgia that have a pretty high prevalence of HIV. So it's not just an Atlanta challenge, even though rates are particularly high as compared to the rest of the state in Atlanta. And cancer incidence and mortality. Cancer is the second leading cause of death in Georgia and nationally. This data here is from the National Cancer Institute, and it's all sites, all stages of cancer. So looking at a particular type of cancer in a particular community may be of interest if you're looking at the community level, and we're happy to work with you if there's something that's of particular interest there. But looking just kind of high level at cancer incidence and mortality, see in rural communities, cancer incidence is similar in rural and non-rural counties, actually slightly higher in non-rural counties, but cancer mortality is higher in rural counties. So there may be many reasons for that, but we thought that was important to share. Okay, so last one on indicators before we move into some of the community work that I wanted to share with you is around health professional workforce. Physician ratios are far lower in rural counties than non-rural counties. We all know this well and have seen many of these figures before. All rural counties are health professional shortage areas for mental health and dental care. And most are shortages for dental care and primary care, and all are shortages for mental health. And there are 9 counties in Georgia, all of them are rural, where there is no physician at all. So again, before pivoting, I just want to reinforce that this data is a snapshot. As we deepen our work around rural health and health policy in Georgia as the Georgia Health Initiative, we are again a resource and happy to work with you. Okay, so the Two Georgias initiative. This is an initiative that Healthcare Georgia Foundation, now Georgia Health Initiative, started back in 2017. These here on this slide are the communities where these efforts took place. There are 11. They're starred around the state, so pretty representative of different corners of the state and all rural. So this was a 5-year, $10 million commitment that Healthcare Georgia Foundation designed and implemented together with these 11 local community coalitions. And what's really different about this work is that the community coalitions themselves identified the health issues to work on, and they led their efforts locally. And what the foundation provided was structure, funding, and resources to support the work that they decided was most important. And the priorities were really unique to each community. They were around behavioral health, health education and prevention, food distribution, community gardens, and more. Some of the challenges that we found, transportation barriers, lack of consistent high-speed internet, and limited access to healthy and nutritious foods were common themes and were shared across many of the communities. These communities really had some impressive accomplishments in their selected areas. So it's important to note that this project didn't fund an intervention per se. It wasn't just a program. It was the structure and funding, and it prioritized capacity building and relationships locally. And this helped community partners who may not have worked together before have a chance to meet each other, understand and catalog some of those community assets, work together to apply for other funding, to make a plan for their community. So it was really pretty cool. It served as a catalyst in a lot of ways to help these communities become better prepared to respond and to engage with themselves and with external partners. And participating communities in this initiative really leveraged a lot. And since 2017, they have combined received about $7.3 million in state and federal grants. So again, part of our goal coming in from the philanthropic sector is really to create something sustainable and to help these communities leverage funding and support to do what was important to them. Okay, so we did an external evaluation, or we had an external evaluation conducted for the 2 Georgia initiatives. So we captured some of the impact that isn't always quantifiable as well, and I wanted to share that. We identified 5 key factors for change. Those are changes in mindset. That was very apparent, just a sense of hopefulness, stronger collaboration, shared vision, community capacity, and leveraging resources. And I talked a little bit about that. Many of the local collaboratives that were formed built relationships with public health, area agencies on aging, extension services, and other entities in their communities. So I think I know there's a lot of words on this slide. I think I hit on all of them, but we also have very numerous publications. We have a long evaluation and also a great summary of this project if it's of interest. And if one of your communities that you represent was also part of this project, and it's something that you're not familiar with, we would also be happy to share more details about what happened locally in the communities you represent. So I think with that, I will stop there. I've put my contact information on the slide. As you develop strategies around improving rural health, please consider us a resource. We really look forward to working with you, whether it be helping to identify data, best practices, or sharing additional information about our previous and current work in communities around the state. So thank you so much for your time, for listening, and really appreciate it.
Thank you, Cindy. Can you pause for questions, please? Any questions?
Yes.
Darling? Go ahead.
Thank you. This was great information. I appreciate it. I did have a question with the number of providers in a particular area. Is it where they practice or is it where they reside?
So that data is from the Georgia Board for Provider Workforce, and I will have to get back to you on that. I think it is sort of where they have their, where they register with the board. But I want to make sure I have that correct, so I'm happy to look that up for you.
Okay, thank you.
It's where they live.
It's where they live?
If that's where it's from, it's where they live.
Okay, thank you.
Representative Court.
Thank you. The slide before this one, you identified 5 key factors. Can you go back? Yeah, just can you go through that? Explain this slide. I know we went through it real fast.
Yes, absolutely. So as part of the external evaluation for the Two Georgias initiative, we also captured some of the less sort of number focused accomplishments from the effort, some of the outcomes. And so these are kind of 5 of them, and these are also what were considered outcomes that better position these communities to be able to work together in the future, to be able to implement policy locally, to be able to take in state and federal funding and really have collective impact. And so the first one around changes in mindsets, the finding here was that at the start of these projects, when going into the communities and speaking with some of the participants in the effort, there was often a sense of futility, that the challenges were so big in the community, how will we overcome them? And through this 5-year process of working together, they left with more of a sense of hopefulness. Oh, I can see, we have this asset over here. We have a group I didn't know about. If we come together, we can do something. So that shift was tangible. The second, stronger collaboration. This was a requirement of the initiative for organizations to function as a coalition locally. It couldn't just be one organization. So that collaboration happened, and it included local businesses, local governments, schools, nonprofits. And so that was an important factor that helped them be successful. Third one was around shared vision. As part of the initiative, each local collaborative had 1 year to essentially plan. And so this gave them a little breathing room and a little space and some structured time and some technical assistance from external providers to sit down with them and identify the needs that they wanted to address locally. And that way, the community selected it, selected what they wanted to focus on, and felt more bought in and kind of on the same page about what they wanted to accomplish. And then community capacity. This was really focused on gaining an awareness of what the existing resources were in the community and then what the gaps were, and taking a strategic approach to expand that capacity by developing new programs and services and coming together to find other ways to apply for other funding or work with policymakers or others to really expand what they can do, their ability to do things locally around health. And then lastly, leveraging resources. Again, the idea that philanthropy can't do everything. It really requires lots of partners. So leveraging these initial investments to build relationships, apply for other funding, and sustain the local relationships and local collaborations, and then sustain the work ultimately over time. So those were, through interviews with participants, those were the 5 key observations about outside of the sort of measurable, quantifiable impact, what helped these local collaboratives be more successful.
Thank you. President Burkle.
Thank you so much. And thank you. There you go. There we go. I think I punched a time or two too many. For Chairman Taylor, I know in Turner County there are, I have 3 physicians in my neighborhood. I list 0 for the county. So for mine, it's where they actually work, or where they practice and not where they live. But it might be different in other parts of the state. I noticed on the health coverage that we use as a snapshot to look at the mortality rates, the cancer incidence, the healthiness of our communities. And you don't have it here, but I suspect if you have an overlay of where lower health coverage rates are on top of per capita income, I suspect there will be a very, very strong correlation. It's at the point that a family of two that pays $25,000 a year for health insurance coverage in a county with 0 practicing doctors, which I don't understand I don't understand how do you do that? It's like paying the same rate for flood insurance in New Orleans as you do on the mountain in Gilmer County. And I don't know why it is so expensive and it's beyond the reach. So in some of our smaller communities that we all live in, if you don't work for the state or for a large business, if you work for a metal fabricator, okay. It says my insurance friend to the right.
Darlene, those are some of the better risks.
The metal fabricators are? Well, they're
I
hard
learned
workers.
something.
They're hard workers. But if small businesses that employ a lot of citizens in our great state, in our rural areas, we work for small businesses. And do you know if there's a push, if there is an incentive of pooling together some of our small businesses into a group? Is there another way? Because $25,000 a year, I'll be honest with you, is not tenable. In just to get a card that to take to a provider that does not exist in your community, but just to have the card is not a sustainable feature unless we can pool risk in small businesses. And I know some of the business community might have some of these things, but I'm just looking for areas. If this is a snapshot, if this actually is something that we can tie to better health outcomes, having health coverage, and right now it's $25,000 for even in areas where we don't have good coverage. Are there other avenues that you're looking at that would that would allow that number to pop up a little bit?
Yeah, thanks for the question. I mean, first, you're absolutely right that income and health coverage do correlate. I think I'm going to leave that to all of you as the policymakers. If there are, if you have a request for some research on best practices, we can work to pull that together. Off the top of my head, I'm not sure that I can necessarily speak to what's happening in the small business market around health insurance right now. But there's, I think, lots of potential solutions out there. Our uninsured rates are, as a state, much higher than the country as a whole and most other states. So there are some workable solutions out there around the country. So I think, again, I'll leave it to you all as the policymakers to think about what might work best as a solution there. But again, happy to circle back with you and pull together some best practices or ideas if useful. And thank you for the question.
Representative Taylor.
Thank you, Mr. Chairman. Just a couple follow-ups. With the work that you do you work within the local communities with like the FQHCs to see the level of care they're getting? And does your organization have any, I'll call them navigators or people that will help those that have access and are eligible, but they have not taken that step to get signed up for coverage?
Right. So through not directly, we do not employ navigators or do that work directly, but through our partnerships and through some of our grant making over the years, we have worked with FQHCs, we've worked with nonprofits, and do see a lot of potential there for some of that kind of community level navigation and education to help consumers with health insurance options for sure, but we don't do that work directly.
Okay, it's through your network of folks you work with. Okay, and Representative, Chairman Purple, that was one of the things, in different communities, you have your FQHCs that can help those that need help find the right level of coverage. And sometimes there's a cost to it, and there is available coverage out there, but people are not aware of it. As far as pooling, that's something we have to take up with the insurance commissioner. Thank you.
Yeah, question. Mr. Chairman.
Thank you so much. What a great presentation. And looking at the uninsured children in these counties, it looks like we are doing well to cover the number of uninsured children based on the state level and the national level. Is that your perception?
As compared to adults, yeah, far higher numbers of children have health insurance than adults in Georgia because of Peach Care for Kids and Medicaid and the really, kind of consensus and focus on the importance of health coverage for kids. There is variation around the state, and Georgia, as a state, has often shown up a little worse than the nation as a whole in terms of eligible but unenrolled. And so that is kind of back to Representative Taylor's comment, speaks to opportunities to provide assistance with outreach, enrollment, navigation. And we'll just add to that, we all know the redetermination process that is going on now through the Department of Community Health as the result of the end of the public health emergency. And so we are trying to watch that as well to look out for potential coverage losses. I think there might be some opportunities to try to address some of that in the future. So,
Thank you so much. We appreciate your presentation this morning. Thank you so much.
Thank you all.
We had you'll notice that we have a number of seats empty. As was alluded to earlier, there are 3 other committees going on in Statesboro, and they're making the rounds on that, so they'll fill on up a little bit later. But we had one individual come in. Chairman Parrish, you want to introduce yourself?
Thank you, Mr. Chairman. I'm glad to be here. I'm sorry I was a little bit late. I was down in Savannah attending another meeting this morning, and everybody was enjoying the new expansion going on at the convention center down there that Chairman Stevens and the Savannah delegation have helped to occur, and that's going to be a real jewel in our crown for our tourism and economic development in that area. And if you just ride down I-16 and look at what's going on with the Hyundai plant over there, you're impressed with that. But we're still working on health care, and I want to remind the members that this House has been a leader in health care improvement over the years. And I don't think that's a story that gets out like we would like for it to sometime, but there's a lot of things going on that this House has initiated that have helped to provide health care across the state. Like Chairman Taylor mentioned, the FQHCs and others who sometimes that is the health care in some areas around the state. And the fact that you all have helped to establish scholarships to help pay back student loans for these providers who want to go to underserved areas and will work there to help pay off some of their student debt. And a lot of things are going on. The fact that you just established a 4-year medical school this year down in Savannah to generate doctors coming out in some other areas of the state, as well as increase the number of nurses coming out and some other things like this. So we've got a lot more to do, but we've made a lot of progress. And I think the members of this committee in the House can be proud of the things that we've done, and I'm looking forward to the information we're getting at this meeting, and thank y'all for what you're doing.
Well, thank you, Mr. Chairman. That's, your leadership has been vital to all of this, and we look forward to hearing from your, findings a little bit later on down the line. We will, when we're speaking into the mics, we need to sort of pull back and not, because it was coming across a little bit fuzzy, to people that are listening in, to us this morning. So, the next individual up is going to be Anna. She's the Executive Vice President of the Georgia Hospital Association, and she's going to talk to us about rural hospital tax credits. Little update there. Thank you. Anna?
Thank you, Mr. Chairman, members of the committee. I am very excited to be here before you today to talk about some really good news. I could not echo Chairman Parrish's remarks anymore. We are so very grateful to the General Assembly for everything that you've done for the Georgia rural hospitals, especially through the Georgia Rural Hospital Tax Credit. And so today I wanted to provide you with an update about what those hospitals that are GHA members are doing with those funds and what it looks like in those communities. So I wanted to start with a brief refresher. Thank you again. In 2022, you all raised the cap for the Georgia Rural Hospital Tax Credit to $75 million. And so far this year, we are sitting at $72,093,260 in total tax credits applied for. So there's still $2.9 million outstanding, but we have a little bit of time before the end of the year. And I do feel confident that those will get taken up. But I wanted to go through today just some of the reports that we've gotten from our hospitals so that you can see how much these funds mean to these facilities and what they're doing with them. I think over the years, there's been a misconception that some of the donations from the Rural Hospital Tax Credit were simply going to offset a hospital's bottom line. But that is not the case. And I think that you will find that these community stories that we're getting are really inspiring. So the first I wanted to talk about is Coffee Regional Medical Center. They have used their rural hospital tax credit dollars to complete a brand new second cardiac cath lab in their facility. Through that cath lab, they have done 4,000 procedures. That is a big deal for that area of the state. 650 PCIs, and they feel that they've saved 100 people as they've intervened in 100 active heart attacks. So those are some real numbers. Those are real people. Those are real lives that are being saved through this program. The second story is through Clinch Memorial Hospital. They have used their rural hospital tax credit dollars to really support their ventilator and trach weaning services. This is an area that is often overlooked in some of our rural hospitals in particular. This is a real area of need, ventilator and trach weaning services. So they've been able to implement that program within their hospital, buy additional equipment, and it has meant the world to their community. Chattooga Regional Hospital and Union General Hospital up in Blairsville have used their rural hospital tax credit dollars to purchase 2 brand new MRIs. Their existing equipment prior to this purchase was more than 15 years old. And as you probably all know, when you go to the hospital and you need imaging, you want to make sure that it is the newest, the latest and greatest state-of-the-art technology. That's how you're going to get the best images. That's how you're going to get the quickest diagnosis. And so for rural areas, especially those that are really far removed from urban areas, it's really important that they have access to that type of equipment. And they were able to do that in Blairsville through this program. Colquitt Regional Medical Center has started a radiation oncology program in their area. This is a really big deal, again, for this area. The patients there previously were having to drive 200 plus miles for radiation services, but because they were able to install the brand new linear accelerator down in that area, they have now done 4,000 treatments, radiation oncology treatments, for more than 200 patients in that community. Appling Healthcare has used their rural hospital tax credit dollars to install a new Meditech Expanse EHR platform. So that is an electronic health record platform many of our hospitals are trying to install, again, the latest and greatest electronic health records that doesn't just provide the facility itself with access to that service, but also allows patients to log in on the back end. So it kind of puts patients back in the driver's seat when it comes to their care decisions. It lets them have access to their own medical information. And it really is a big deal for rural areas because that's the kind of thing you typically see in a larger urban hospital. But to have that in a rural location really does allow them to feel more connected to their healthcare providers. They've also used their funds for additional nuclear medicine equipment and portable x-ray machines, which they've been able to use at the bedside. And then my final example today, Candler County Hospital. This is an excerpt from a newspaper article that recently was published, but I want to call to your attention one quote from this article. They said that the rural hospital tax credit dollars have, quote, saved their hospital. That is such a huge deal for that community. They've talked about the dated facility that they're currently in and what their plans are moving forward. But the economic impact of having that hospital in that rural community, even if it isn't new, even if it needs some improvements, is such a huge driver for employment opportunities, for tax dollars coming into that local community, all stemming from their ability to participate in the rural hospital tax credit. So I wanted to talk just a little bit about the influence this program has had, not just on Georgia, but nationwide. So GHA, some of you may be aware, we have relationships with other hospital associations in other states. And I can't tell you the number of times I've gotten calls from other hospital associations where they've said, you have done a really great job in Georgia in supporting your rural hospitals through the Rural Hospital Tax Credit Program. Tell me how it works. How can we make this happen in our state? And so our most recent conversations have been in the state of Alabama, and they are looking into what they could do to try to mimic or at least do something similar for their rural hospitals. And we were the first in the nation to do it. So I want to commend you for that. And again, thank you for this innovative idea and for continuing to come back to make improvements. You know, with any new program, you often have to work out some kinks. And over the years that has happened. There have been a couple of iterations of this bill, some changes that have been made that have really just improved it along the way. But one thing I do want to highlight, because this came up this last legislative session, why a rural hospital tax credit? Why not just direct appropriations to hospitals? That's been a question that has come up year over year. And I want to highlight for you that the rural hospital tax credit really fosters engagement from the community. When those local businesses and those local patients and leaders within the community are making those contributions to their own rural hospital, it gives them some skin in the game. And they feel really responsible for the success of that hospital after those donations have been made. And so it helps with the community support in a way that direct appropriation simply can't. And so I want to thank you for that. So I thought we would go over just a couple of the things that the legislation last session that was introduced aimed to address. So Representative John LaHood introduced House Bill 363 this last session, and I wanted to just go over some of the things that that bill did. So the first item, it revised the definition of a rural hospital organization to include a brand new federal designation called a rural emergency hospital. Right now, there are 16 rural emergency hospitals in the United States. This is the process for an existing hospital to convert down, close their inpatient beds, but continue to offer emergency services within their community. We have one in Georgia. We have a couple more that are considering that. And the question has come up, why would a hospital consider doing that? It really is about funding. Do they have the patient volume and the ability to continue to operate with open inpatient beds if they don't have the patients in those beds? When you're staffing them and you're keeping up with all of the other items that go along with operating a full hospital, they simply can't afford it. And so we want to make sure that those hospitals still have the ability to participate in this program so that hopefully along the way, they will be able to find some footing and be able to reopen as a full acute care hospital. So this would include them in the rural hospital tax credit. The second item that it addressed, it increased the tax credit limit of pass-through owners from $10,000 to $25,000. This is really just kind of an incentive for those businesses that want to participate in the program. They can't make these donations until the second half of the year anyway. So for those funds that are remaining after individuals have taken up those tax credit dollars, we want to give them a little bit more opportunity to participate on a one-off basis. The third item, it increased the statutory cap to 100 million. This is something we would love to see happen. We feel that it would be utilized, and we think that each of our individual hospitals could really use that money, again, for projects to help with the community patient load. It allowed the Department of Revenue to issue proportional credits to the donor equal to the amount remaining under the hospital annual limit. This is an important one. So each hospital has a $4 million cap for what they can accept annually through the Rural Hospital Tax Credit Program. If a hospital has raised $3.5 million, but a new donor comes in and wants to do $750,000, it would put them over the limit. Currently, that entire new $750,000 would have to be rejected. This allows for a partial donation so that that new donor could go up to the hospital's cap and then it would cut off. So it stops some of those donations from getting kicked out arbitrarily. And then finally, it sets a deadline of 180 days or October 31st for collection of contributions to allow time for the unused credits to be reawarded. Currently, the deadline is December 31st. So those who apply for those credits through the Department of Revenue have until December 31st to make that payment. We often at the end of the year see donors who don't end up making that payment. And so we lose anywhere from $500,000 to $1.5 million in donations every year. So we'd like to back that up to October 31st so that if those donors haven't made that payment by the 31st, we can go back to the wait list and get those individuals who are waiting to get into the program. The sunset for the Rural Hospital Tax Credit Program is currently next year. So we've got until the end of next calendar year for this program to continue. Again, we would love to see that extended. The initial proposal here was 2029. There was a version of this language that was included in House Bill 504 at the end of last session that had already crossed over to the Senate that would have extended that sunset to 2026. We will take it. This is such an important program. We want to see it extended year over year. We talked about this, but this is just some additional information about the rural emergency hospitals. And you all have a copy of this so that you can have it for future reference. The 10,000 to 25,000 we discussed. It talks about the ability to get those larger donors participating in the program so that they see it as an attractive option. Increasing the statutory cap, you all did that in 2022 from 60 to 75 million. Representative Perkle carried that legislation. Very, very grateful for that. There was some talk this session about potentially going up from 75, not all the way to 100, but the version in House Bill 504 that has crossed over does not at this point in time include a statutory or a cap increase. That's okay. We care at this point about the sunset being extended. This goes back to those partial contributions, just a further explanation so that you have that for your records. This further explains the deadline with that number between 500,000 and 1.5 million in donations lost due to the inability to get those funds because of the December 31st deadline. And then here is an overview of House Bill 504, which is the one in the Senate that if they were to pass that would come back over to the House for an agree. It includes the rural emergency hospital clarification, the partial donation approval when hospital cap is met, the deadline for approved donation payment, moving that back to October, and then extending the sunset to 2026. So as we reached out to our members and asked for anecdotal stories, tell us what you're using these funds for, everyone was so very grateful. And so I wanted to make sure, again, that I highlight how much this program means to our rural hospitals in the state of Georgia, how much we would like to see it continue, and how very grateful we are to you all. So I'm happy to answer any questions.
Thank you for that presentation, and we're all interested in the rural hospital tax credit. Any questions from the committee? Okay.
I've got one for Anna. Anna, you mentioned the $4 million credit. How many of our hospitals actually hit the $4 million credit?
I can get that number for you. It's not a lot, and it really just depends on how much the hospitals are pushing this within their
Right.
community.
I know ours was like 2.8 or 3, and I mean, that's a godsend for us. And if
And-
people aren't participating, I'm gonna give you a shout out. I mean, this is the greatest thing for our rural hospitals.
Thank
And
you for
when I
that.
say rural hospitals, not these other hospitals that claim to be rural.
Yeah, and
And there's some of them that do.
well, since you brought it up, I have a list of other things that are not included in my slides that hospitals are using these funds for. And some of them are things you may not think about from a hospital perspective. One of our hospitals has used these funds for commercial large washers and dryers. Hospitals have a lot of laundry, and those things are expensive. And when you talk about the costs rising of supplies and workforce, et cetera, washers and dryers fall to the end of your list. And so these kinds of funds allow for them to have that kind of equipment. Mobile mammography units, that was a huge deal for the community that went into. Emergency department renovations. Everybody wants to go into the latest and greatest emergency department. You want to feel like it's clean and new. And they use these funds for that purpose.
President Perkle.
How about that? All right, Leo, I'm not gonna get too close to it so it distorts. I think Chairman was talking about me when he mentioned not get too close. I would like to thank Chairman England and the late great Chairman Jay Powell for their absolute leadership in making this a program that is doable for our hospitals. This is an absolutely wonderful program for our rural hospitals. It is a lifeline. It has saved many rural hospitals. One thing that I should probably know that I think I have forgotten is there is a $10,000 cap presently in place. I seem to recall in the code section that after, say, June, there's a number, there's a date. After June, that cap goes away, and I can, is it July 1? Well, let's say June 30. He's got to be right. Say July 1, that cap actually goes away. Is that correct?
I think that's for individuals. So the first half of the
Uh-huh.
year is for I hope I'm not messing this up, but if I am, I can get you this information. First half of the year is individuals. After that is corporations.
But my question is, with Chairman Hood's bill that he has pending,
Mhm.
do you know if there are any changes to that in his, besides increasing from 10,000 to 25, does it change that July 1 date?
It does not.
Okay, thank you.
Yes.
Any more questions from the committee? Thank you for the presentation.
Thank you.
And we're really certainly enjoying it in Washington County and some of my other counties in my district. Thank you.
Thank you very much.
Thank you, Anna, so much. We appreciate what you do all the way around. We're going to deviate from the agenda here for a moment. Senator Billy Hickman wants to speak to this just a moment because he's between you and lunch.
Well, and I appreciate it. Thank you so much, Mr. Chairman, for letting me do this. I just want to speak on the rural hospital tax credit. All of y'all know how passionate rural Georgia is for that, and how great a tax credit this is for rural Georgia. You know, the counties that in our district, that Senate District 4 that reap benefit from this is Evans County, Candler County, and Effingham County, and prior to redistricting, Emmanuel County was part of our district. I can go through and give you the same information on those counties that Anna just gave you for these counties up here. It has been a game changer, life changer in those counties. It has kept these hospitals open. Chairman Hatch and I toured Evans County Hospital a couple weeks ago, and I think at the end of the tour, the chairman, in his own wisdom, said, "When I was here in 2017, I didn't think this hospital will be open in 2023." And they're thriving, they're doing well. These three hospitals, Evans, Candler, and Effingham, employ a little over 1,100 people. So that's 1,100 families that are affected by these hospitals. And we've got to make sure these hospitals stay open. It is very, very important. I look at this situation as a four-legged stool. I had it as three-legged at one time, but it's a four-legged stool. And in order for a community to really survive, and good many of y'all from rural Georgia, you know this better than I do, or as well as I do, you got to have a great education system in order for a community to survive. Nobody wants to live in a community that doesn't have a great education system. You got to have a great transportation system, because you got to be able to get goods and services in and out of a community. You got to have broadband now. We all know what happened as a result of COVID, how important broadband is. And the fourth leg of that stool, and very well could be the first leg of that stool, you got to have great access to health care. If you don't have great access to health care in a community, that community dies. You go through Charlton County, some of you may be in Charlton County, and you'll see the dog kennels at the hospital in Charlton County. We all know how important that is. And this is the great tax credit. Let me tell you, I'm a CPA, as many of y'all know, you can make money off this tax credit. Let me tell you how you can make money off of it. You can get a tax credit at the Georgia level. So you put $10,000 in, let's say $15,000, make it easy. You can put $15,000 in at the Georgia level. So your tax liability is something greater than that. So now you're even. You get a tax deduction on the federal return. So if your federal liability, if you're in a 30% tax bracket, the federal government in Washington, D.C. is going to write you a check for $5,000 for this thing. So it's a money-making situation. So just don't think of it as helping these hospitals. Think of it as buying groceries for your family. I can't say enough about it. It's great, and I appreciate it. Thank you, Mr. Chairman, for giving me this 2 or 3 minutes as a promotional advertisement for a rural hospital tax credit. Thank you.
Senator, can I ask you, we have a question here. Senator, I have a question. Senator, as I recall, this bill has passed the House and it's over in the what's called the upper chamber. What have y'all done with that bill?
Oh, I think we fix to find out. Thank you. Thank you for the jab.
Thank you. Thank you, Senator. You did a great job up in Athens, and we appreciated the information that Representative Jackson and I received up there. We do have lunch that's been prepared for the committee, and Leo has given me the point to, it's in the next room, there. So we're going to break for a restroom break and lunch right now, and then we'll be back at 1 o'clock. Thank y'all.